Hello guys, so today I would like to do a video on the pelvis and perineum, that is the clinical anatomy. So this video would require prerequisite knowledge of the normal anatomy of the pelvis and perineum region. So we'll actually throw bits and pieces of the normal anatomy, but we'll mainly dwell on the clinical anatomy. So we'll start with the much simpler stuff, and then we will go a little bit profounder with our details. So we start with the prominence that is seen in the hips of multiparous females. That is, females who have actually given birth to more than one children. The opposite of that would be a nulliparous female who has actually not given birth to any child. So you'd find that the first difference in these two will be seen at the level of the external os, whereby you see a transverse slit in multiparous females, but then it'll be and you see an oval-shaped slit in nulliparous females. So let's talk about what really makes the hips in multiparous females more prominent. So during pregnancy, as a general rule, that is physiologically, remember that you release a hormone that is known as relaxin, and this relaxin hormone will actually help in relaxing the pelvic joints to allow for movement, to guide the baby, that is for smooth passage, as well as smoothening the ligaments that normally tighten the pelvic joints. Then after parturition, that is childbirth, you then realize that there's a decrease in this relaxin hormone, and these ligaments will not actually regain their original efficiency. So the pelvis will then remain wider, thus we end up having hips in these multiparous females. Then we also have a gait that is seen in late pregnancy. This we can relate to what we call the lumbosacral angle, that is normally 120 degrees. So this lumbosacral angle, which I'll show in a picture on the next slide, is an angle that is between the fifth lumbar vertebra and the sacrum. So it opens more posteriorly because the intervertebral disc between the L5 and S1 vertebrae is thicker anteriorly than posteriorly, which I'll then show on the next diagram. So normally the forward tilt of the upper end of the sacrum as a result of weight is prevented by the ligament. So remember that the sacrum is now sort of carrying the entire spinal weight. So this forward tilt of the sacrum is prevented by the ligaments. So then in late pregnancy, as I alluded to earlier on, we say that we have relaxation of ligaments being caused by relaxin hormone. That means that relaxation of these ligaments and the additional body weight that is actually being added due to the uterus will result in the upper end of the sacrum tilting forward during walking. So you then realize that these women, they tend to fall forward, right? Their bodies tend to actually sort of like fall forward. Then with time, you then realize that they then assume a walking position whereby they actually have a backward tilt, sort of like bending their backs backwards so that they don't have this forward tilt. So that's the reason why women in late pregnancy, they then tend to resort to their backs for support because of this forward tilt that would then be happening due to a forward tilt of the upper end of the sacrum that is due to loss of support by the ligaments. Then we have what we call spondylolisthesis and spondylosis. Take note, these two are actually different. So you'd find that spondylolisthesis is more common at this lumbosacral angle, but it can happen anywhere along the vertebral column, just sort of like a forward slippage of the top bone relative to the bottom bone. So that is you're relating the bodies now, and this condition actually affects the young and the old. But then the causes for both the but both the ages will actually be different, because you'd find that in young children it's more as a result of injuries, but then in the old now it's now more as a result of the loss of ligamentum support and fibrosis of ligaments in general. So this is more of a diagram to show that lumbosacral angle that I earlier on alluded to, and we say that it opens more posteriorly because the intervertebral disc is more thicker anteriorly. And then this spondylolisthesis, I then say that it's different from spondylosis, that is weakness now between the pedicle and the body. Remember that when you talked about the normal vertebral structure, you say that from the body, projecting from that body anteriorly, you found pedicles that then left a gap that is below and the gap above. The gap above was the smaller one, and then the gap below was the larger one. That inferior notch together with the superior notch of the vertebra below will then form an intervertebral foramen. The intervertebral foramen will then allow for spinal nerves to exit. And then you will also have veins as the channels that allow for communication between the external vertebral plexus of veins with the body wall veins. So you take note of the difference now that is between spondylosis and spondylolisthesis, and spondylolisthesis can actually end up causing spondylosis. So we then talk about the fetus now in the pelvis during parturition. So mainly the baby's head adapts itself to the different dimensions of the pelvic cavity for it to pass smoothly during a normal vaginal delivery. So initially the head of the fetus faces toward like at the pelvic inlet, right? It's in the anterior posterior diameter of the head lies transversely at the inlet. That is, it's in the right and left axis. But then when it then leaves the outlet, it versus its anterior posterior diameter will actually be in the correct anterior posterior axis. That due to the fact that it actually turns 90 degrees as it actually moves through the pelvic region. So this would be important to understand, I guess, in those who want to venture in obs and gyn. Then fractures of the pelvis are more or less common, and it acts as sort of a ring. So if we then have dislocation or any displacement of any part of the pelvic ring, you then realize that you have a fracture at two different points. Because remember, for a normal ring, if you fracture it at one point, you don't have displacement of any part of it. But then if you then fracture it at two different points, then you have displacement occurring. So this displacement can either cause lateral compression or anterior posterior compression within the pelvis. So for you to fracture the pelvis, you then require a direct violence that is of high velocity to fracture it, since it's more of a ring and it's very strong. So the weaker regions would be the sacroiliac region and the pubic symphysis that is anterior, and taking into consideration that the pubic symphysis anteriorly, or rather the anterior wall, is rather shallow, and there's that pubic symphysis being rather forming part of it, that is a secondary cartilaginous joint form that actually is lined by hyaline cartilage and there's a fibrocartilaginous disc within it, allowing little or no movement, but then being relaxed by the hormone relaxin that we talked about earlier on. Then the sacroiliac joint normally being a synovial joint, but then it then ends up being fibrous in the old age, which is then why those in their late 50s and 60s then assume that stoop position in walking. So if you to have anterior posterior compression, you may have dislocation of the pubic symphysis, and dislocation of the pubic symphysis may have effects that will then affect the bladder. We'll come to that towards the middle of this presentation. Then, so that's the anterior posterior compression, and we talked about the bladder and the urethra that are more likely to be injured. Then the rectum will also be one of the structures that will also be more likely injured. Then we then come to the pelvic diaphragm. So the pelvic diaphragm is made up of the levator ani muscle and the coccygeus muscle. The coccygeus muscle being the muscle that actually arose from the ischial spine, then goes to insert on the anterior surface of the coccyx, and then the sacrum above. Then the levator ani having that linear origin from the back of the symphysis pubis, then a tendinous arc from the obturator fascia. That tendinous arc may leave a gap that we'll talk about soon. That is the hiatus of Schwab, whereby you may have herniation of pelvic viscera now into what you call an ischial fossa that is bounded by the levator ani medially, and then the obturator internus muscle laterally. So this pelvic diaphragm may be injured during parturition, and they say that if the pelvic diaphragm is injured during parturition, that means it will actually be more difficult for it to heal as compared to rather the perineal body. Because remember, the perineal body is extremely important to maintain the integrity of this pelvic diaphragm, right? So you then remember that if you injure this perineal body during a normal childbirth, it's harder for it to regain its stability than an induced injury that is done when you then do what you call a median episiotomy, which we'll talk about shortly. Having a median episiotomy or a mediolateral episiotomy, that is rather a posterolateral episiotomy. So should you injure the pelvic diaphragm, you're more likely to have uterine prolapse and rectal prolapse, because remember that part of the levator ani, the puborectalis, form that sling around the anorectal junction. So you're more likely to have rectal prolapse or uterine prolapse. Rectal prolapse can also be caused by loss of fat in the ischial fossa, which we'll talk about when we talk about the ischial fossa. So in episiotomy, we make an incision in the perineal region. So this is different from a normal cesarean section that most people are familiar with. So we make this incision in the perineum to enlarge the vaginal orifice so that we allow for childbirth. So we can either have a median episiotomy or a mediolateral episiotomy or posterolateral episiotomy, whichever way you may want to call it. The difference between these two will be the structures that will actually be pierced and the structures that are more likely to be injured. And then median episiotomy generally heals faster as compared to mediolateral episiotomy, despite the fact that in mediolateral episiotomy, you have less structures being injured because you only look at cutting through the skin, the vaginal wall, and the bulbospongiosus muscle. But then when you then talk about a median episiotomy, you are more likely to injure the external anal sphincter. And injuring the external anal sphincter, I guess you and I, we know what will then happen. And on top of that, you're more likely to cut through the skin, the vaginal wall, and the perineal body, as well as the muscle that is known as the superficial transverse perineal muscle. Remember, we have a deep transverse perineal muscle that forms part of the urogenital diaphragm together with the sphincter urethra. So the median episiotomy is done from, it actually begins at the frenulum of the labia minora, that is the two unfused urethral folds in the femur, but then in mediolateral, it starts there, but then it proceeds at an angle of 45 degrees going posteriorly, as compared to a median episiotomy that just goes straight in a midline. Then coming to what we were talking of as the ischial fossa. The ischial fossa is that space, I would say it is bounded medially by the levator ani, then the obturator internus muscle on the other side, then they meet to form the tip. Then in this ischial fossa, we find foot, then we have a pudendal canal that has the pudendal vessels, then it's crossed by the inferior rectal vessels as they gain access to the anal canal, actually being branches of the pudendal vessels. So this ischial fossa is prone to infections due to its location. It's in an exposed location. So the infection may occur from boils or abrasions and may cause an abscess. That is, the abscess we're referring to accumulation of pus within a region, that is within tissue. So this issolator abscess, you'd find that there is not much pain associated with it when you compare it to a perianal infection, where the fat in the perianal region is more tightly pegged. So even with tension here, there is little swelling because of the fat, because the fat within this fossa is loosely arranged. And this fat would be important because if this abscess were to burst into the anal canal or the surface of the perineum, you then have what you call anorectal fistulas or fistula in anus. So anorectal fistula rather is an abnormal communication between two organs. So if you have this abnormal communication, that will mean the fistula in ano one, you have an abnormal opening on the surface of the perineal skin that leads into your anal canal. So as I was saying, the fat is important because it provides a cushion-like support to the rectum and the anal canal. So you then find that in weakening diseases that are debilitating as diarrhea in children, you may then have rectal prolapse just because you then have lost the fat that was actually acting as a cushion on the lateral sides of your anal canal and the rectum that are in the midline. And then an infection may actually pass from one urethral fossa to the other, that is through a horseshoe-shaped recess that is posterior to the anal canal. So you then find that these urethral fossas, they actually have three recesses: an anterior recess, then a posterior recess that actually grows towards the ischial tuberosities. Remember, the ischial tuberosities, they form the most lateral boundaries of the urogenital triangles, the urogenital triangles and the anal triangles as well. Then that horseshoe-shaped posterior recess then goes posterior to the anal canal to allow for communication, and you may then have infections traveling to the opposite side. Then earlier on, I alluded to what we call the hiatus of Schwab, that is a tendinous gap, or a gap that occasionally exists between the tendinous origin of the levator ani and the obturator fascia. So this hiatus may allow for pelvic organs to herniate into the ischiorectal fossa. Then within this ischiorectal fossa, we say that we find the pudendal vessels. These pudendal vessels will be important for normal operations that are done within the pelvic region, because it's the nerve of the pelvis and perineum. So there are two ways of operating this pudendal nerve block, either by infiltrating the vagina or the rectum to palpate the ischial spine and then guide the needle block towards that. Or you may use a surface landmark, that is the ischial tuberosities. Remember, we actually sit on our ischial tuberosities. So if you carry the pudendal nerve block bilaterally, you then find that you have loss of the anal reflex. Remember, the pudendal nerve will actually, by nature, it by nature being a somatic nerve, it will actually give innervation to the external sphincter. So it's going to innervate the external anal sphincter. Then moving on to the bladder, we have what we call suprapubic aspiration of the urinary bladder. So usually when the bladder is distended, remember we say that it peels off the peritoneum. So if it's going to peel off the peritoneum, you can now aspirate the bladder suprapubically without injuring the peritoneum. That is taking a urine sample that is done mostly in children below the age of 2 for you to assess their urine. Then for more clinicals on the bladder, we have what we call a trabeculated bladder. Then we have a neurogenic bladder. So a trabeculated bladder is just more of a chronic obstructory condition, because you then have urine not being able to leave the bladder, either by having a larger prostate and a benign prostatic problem that would then compress the urethra or you have a stricture that is within this urethra, and then you prevent urine from actually leaving. So the bladder will become distended and its musculature hypertrophies in such a way that it gives an open valve appearance that is known as the trabeculated bladder. So you then realize that with with time, the elasticity of the bladder wall will be hard to, or the bladder wall will not regain its normal elasticity if this condition were to persist for long. Then a neurogenic bladder, by virtue of saying neurogenic, I guess that's what moves me. We have micturition centers, of course, a lower micturition center that is the S2, S3, and S4 region of spinal nerves. Remember, that is actually the sacral outflow for the parasympathetic, and those are the nerves that we then refer to as the pelvic sphincter nerves. Then we have a higher micturition center, of course, that is somewhere higher up there in the pons and medulla. So micturition is essentially a reflex that is controlled by both sympathetic and parasympathetic fibers. Remember that for sympathetic fibers, they'll actually relax the detrusor muscles for you not to urinate, but then parasympathetic fibers will actually cause these detrusor muscles to actually contract for you to urinate. Of course, when you then look at what they do on the sphincters, it'll be the reverse of what they do on the musculature. So for voluntary urination, it's actually controlled by the higher centers, that is the cerebral cortex. But then urination, the lower micturition center, just that to say urinate when it's full, right? So voluntary urination is controlled by the higher centers that is within the cerebral cortex. So any defect within the neural mechanism that surrounds micturition will then lead to what you call a neurogenic bladder. So a neurogenic bladder may arise from different sets of conditions. You may have deprivation of the fibers that are coming from the higher micturition center from the cerebral cortex that are actually part of the pyramidal system. They're not extrapyramidal. And then you have fibers that are actually within the fibers that are coming from that S2 to S4 region, the pelvic sphincter nerves. So for the types of the neurogenic bladder, we will then start with what you call the automatic reflex bladder. So this results from complete transaction of the cord above the lower micturition center. So in a way, essentially, we don't have the upper pyramidal tracts, that is upper motor neurons, coming to feed the lower micturition center. So you lose voluntary inhibition and initiation of micturition because you're no longer conscious about it, and then the bladder will empty reflexly every 1 to 4 hours when it fills. So that means that if the bladder were to fill, it automatically contracts through its detrusor muscles, those three poorly delineated muscles, and then it just releases the urine. Then you have what you then call an autonomous bladder that is different now from an automatic reflex bladder. So this one results from injuring the lower micturition center. So the lesion is now below the segments S2, S3, and S4. And I guess this will be important for you when you proceed with anatomy to note the difference between spinal segments and vertebrae, because even if you were to look at, let's say, the C3 spinal segment, you don't find it at C3 vertebra, right? So you need to take note of the wording there. It's when we talk about nerves, we refer to segments. Then this autonomous bladder clinically presents with loss of the reflex and nervous control of micturition, and the bladder wall becomes flaccid, and capacity of the bladder is greatly increased. Remember, you are now losing tone, but this is more like a lower motor neuron lesion. And then you may have interruption of the sensory side of the reflex seen in what you call TEPS dorsalis. That is more common in syphilic patients. So this leads to an atonic neurogenic bladder, and a large amount of urine will actually collect within the bladder, but you don't have reflex contraction due to the fact that the general visceral afferent fibers that actually leave the bladder, causing upwards going towards the the higher centers that are within either the the dorsal columns of the spinal cord, they won't be reaching that higher center, so you don't have an atonic bladder. Then also, this bladder, embryologically, we have what you call the allantois that actually, or rather the ureka style is the one that we see in normal people, but embryologically during fetal and embryonic life, we have what you call the allantois that actually extends from the apex of the bladder to the umbilicus. So its remnant is what you call the urecas. So you may have a urechal fistula. Remember, we say that a fistula is an abnormal opening between two organs, right? So you may have a urechal fistula that may allow for urine to actually pass through the umbilicus. So normally it's supposed to degenerate and form the median umbilical ligament, while the umbilical arteries degenerate to form the medial umbilical ligaments. Then the lateral umbilical ligaments will actually be used due to those lateral umbilical folds that would then help in determining whether a hernia is direct hernia or indirect hernia. So you may use that, or you may then use the deep inguinal ring. Then still on issues to do with urine, the lumen of the male urethra is actually irregular. So this, the fact that it has different shapes in different regions makes the urine in males projectile. So it means that the early separation of droplets of urine does not occur. So it prevents the wetting of clothes, as opposed to the females that have a shorter urethra that is more regular as compared to that of males. Then we have rupture of the urethra. So for rupture of the urethra now, you may have superficial extravasation or deep extravasation, but the urogenital diaphragm will be your surface landmark to delineate these two now, right? So common site of rupture will be the bulb of the penis, right? That is just below the urogenital diaphragm. So you may then have urine extravasating into the superficial perineal pouch, the scrotum, the penis, and the anterior part of the abdominal wall. This is what we call superficial extravasation. But then if you have deep extravasation, that is loss of, or rather rupture of the urethra above the urogenital diaphragm, you may then have now urine passing above the deep perineal pouch, then the prostate and the bladder superiorly. So that's the difference between deep extravasation and superficial extravasation. Then we then have what we call catheterization of the urethra, which can actually be self-done nowadays, as shown on the pictures that I have attached below. So this is done in patients who are unable to pass urine and their bladders are distended due to retention of urine, leading to severe discomfort and pain in the hypogastric region. So that's catheterization. Remember, we talked about suprapubic aspiration. So this method can also be used to obtain a sample of urine if suprapubic aspiration is not doable. But then if this method is going to present with pain for those, let's say, males that actually have phimosis, that is a constriction of the urethra, then they then need to resort to the suprapubic aspiration that we talked about earlier on. Then we have hypospadias and epispadias. In hypospadias, you have it's a congenital anomaly that is having the opening of the external urethral orifice located on the inferior surface of the penis, that is commonly referred to as the ventral aspect. Then comparing the female urethra and the male urethra, the female one is more dilatable, hence you can pass through a catheter. And urinary tract infections then become more common in females because it's shorter. Remember, the male urethra is around 20.75, but that female one is only around 3.75 centimeters. So you may have retrograde transport of pathogens from the exterior going towards the bladder, or you may, since it's actually closer to the orifice of both the vagina and the anal canal, you may have a retrograde passage of these things towards the bladder. So this is why females are encouraged to bath at least once a day. Then urinary incontinence is actually common in females as well, because they have a tenuous external urethral sphincter that is actually weak, and due to the fact that they also give birth, they are more likely to have urinary incontinence, which we refer to as loss of bladder control, that will actually vary from a slight loss of urine, maybe seen in sneezing or coughing or laughing, to complete inability to control urination. That is, you then just start to urinate without a reflex control of it. Then just below the bladder, you gotta remember that it actually rests on the prostate. The prostate then rests on the urogenital diaphragm in males, but then the bladder will directly rest on the urogenital diaphragm in females, making it a bit lower. So then talk about the prostate, right? So for the prostate, you can have prostatic carcinoma or benign prostatic hypertrophy, which we earlier on alluded to as being one of the causes of blockage of urine leaving the bladder. So prostatic carcinoma, that is more common in those aged 50 years and above, and this cancer is more common in the outer peripheral zone of the prostate. Remember, the prostate will have a transitional zone, a central zone, then a peripheral zone. In the first zone, you find the transurethral mucosal glands. Then you find transurethral submucosal glands in the second one. Then in this prostatic, in this peripheral zone that forms the jungle feet, that is around 75% of the prostate, you then have the main glands of the prostate. So this is where you're more likely to have a prostatic carcinoma. Same applies for benign prostatic hypertrophy in terms of incidence and age. So prostatic carcinoma usually involves the posterior lobe, but benign prostatic hypertrophy usually involves the median lobe, right? So this median lobe will compress the prostatic urethra and obstruct urinary flow. Remember that the transitional zone actually encompasses the superior portion of the urethra. So if you have the median lobe compressing the urethra, that means you're going to probably have stagnasis in urine flow. That is urine that is moving from the bladder. So the enlargement of the uvula vesicae will also be a clinical presentation. Because remember that in front of the urethra, you have what you call the uvula vesicae. I don't know how it's actually pronounced, but this uvula vesicae will actually enlarge and cause what you call the prostatic pouch of stagnant urine in the urinary bladder that is behind the urinary the orifice of the internal urethral orifice. So this uvula vesicae is sort of like a slight projection into the cavity of the bladder just behind the urethral opening, marking the location of the middle lobe of the prostate gland. So that's the median lobe, right? So it's going to erase the uvula vesicae. Then you have a post-prostatic pouch of stagnant urine within the urinary bladder. Then further on, the prostate can also be removed in a process that is known as prostatectomy. This will be differentiated from differentiated from the process that is known as thyroidectomy in terms of the false and true capsules and where the venous plexus actually lies. So you'd find that the venous plexus within the prostate lies between the false and true capsules, but then within the thyroid, it lies deep to the capsules. So within thyroidectomy, you actually remove the venous plexus, but then it's spared in prostatectomy. So after this procedure, the patient is more likely to become sterile because you lose the mechanism of the internal urethral sphincter. You then have retrograde transfer of semen into the urinary bladder during ejaculation. So you won't have semen that is actually coming from the prostate for nourishment. So the seminal vesicle is also known as the gland of Repis, because it's the only place in the body where you have fructose being produced. So if you have to test for forensic evidence of rape using fructose, you're more likely to determine whether there has been a rape. But then seminal fluid generally was tested. Is tested using what you call the Florence test, which actually takes into consideration the presence of choline within the seminal fluid, not the fructose. So further on, we then talk about vasectomy. So it's the most common method that is used for male sterilization. It's a minor operation done under local anesthesia where you just tie a short segment of of each vas, and then you sort of like tie it. So this procedure, they approach through a median incision in the upper part of the scrotum. So it's reversible in some cases, more preferably those who are 30 years or below. Below In terms of years. Then in terms of the female side, you have what you call ovarian torsion. Of course, you also have testicular torsion, which inadvertently, after 6 hours of no blood supply to the testis, you may need to remove the testis because it would have actually undergone gangrene. So ovarian torsion is caused by an abnormally long mesovarium and suspensory ligament of the ovary. So the ovary may rotate along these structures. Then, as for ovarian carcinoma, the carcinoma of an ovary is common and accounts for about 50% of all cancers and 20% of gynecological cancers. So teratomas are cancers of unknown origin, and they're common in the ovary, because remember that during embryonic development, we say primordial germ cells, they migrate from the epiblast to the wall of the yolk sac. Then by amoeboid movement, they move towards the posterior mesentery of the hindgut. Then they go towards the developing gonads, and these primordial germ cells may give rise to either sacrococcygeal tumors, or they may give rise to oropharyngeal tumors, or they may give ovarian teratomas. Then you have ovarian prolapse that may happen after childbearing, and these prolapse may occur and have the ovaries being displaced into what you call the pouch of Douglas. So inadvertently, you may have dyspareunia, that is pain on sexual intercourse. Then for ovarian cysts, you can either have follicular cysts or luteal cysts, but follicular cysts, they are more or less 1.5 centimeters less in diameter as compared to luteal cysts that are actually greater in diameter, that is around 3 centimeters. And then ovarian dysgenesis, that is absence of the ovaries, streak ovaries, is a common condition that is common in Turner syndrome, that is 45XO. Then you may have a webbed neck, a short stretch, and stuff like that. That is Turner syndrome. But you may have ovarian dysgenesis or streak ovaries in this condition. Then ectopic ovaries are also common. Remember that we say in embryonic development, they actually arise from the posterior abdominal wall, in the posterior exocoelomic cavity that is around T10. So failure of migration to their normal position, being guided by the tabernaculum, may result in ectopic ovaries that are actually somewhere up within the abdominal region. And then rarely they may actually be drawn downward with the round ligament of the uterus into the inguinal canal, or they may actually grow down towards the labia benches. So you may have what you call salpingitis, that is inflammation of the uterine tube. Remember, the uterine tubes are very important because they actually form a communication between the female genital system to the peritoneal cavity, which we'll talk about in a short while when we talk about ectopic pregnancies. So the shortest most parts of this uterine tube, with the most lateral part and the most medial part, that is the intramural part, that is a centimeter, and the fimbriated infundibulum part, that is also a centimeter. So ectopic pregnancies may occur in the uterine tube, and due to the fact that there may be no decidual reaction, you may have this conceptus being aborted, and then you have intraperitoneal hemorrhage, which would be a cause of acute abdominal emergence in women of childbearing age. Then tubectomy will just be the same as vasectomy, but now we are tying the femoral uterine tubes. Then cervical carcinoma is also common in the ages of 45 to 55, but is rare before the age of 20. And 80% of cervical carcinomas, they are squamous cell carcinomas that are also known as ependiomas, more commonly seen in skin as well. So early sexual exposure and promiscuity are one of the major causes that are actually cause the onset of cervical carcinomas. So it may actually spread to various regions and metastasize due to the lymphatic system. Remember that we say the pre-aortic and para-aortic lymph nodes, they drain this region, as well as other lymph nodes, pelvic lymph nodes, to measure the internal iliac and external iliac nodes. So you may have metastasis of these cancers to other regions. Then you have what you call a Krukenbeck's tumor. So breast cancer may spread to the ovaries through subdiaphragmatic and subperitoneal lymph nodes, so then spread this cancer um, towards the ovaries. Or you may have the Fissure's lymph nodes that are found on the left side supraclavicularly, having metastasis of testicular cancer in males. Then a C-section, I guess this is no new information, different now from episiotomy that we talked about earlier on. So this is just a surgical procedure that is done by cutting through the abdomen and the uterus in cases where vaginal delivery is not possible. But then to take note, you need to have prerequisite knowledge of the normal location of the bladder, if it has been drained before the process, or if it is full, because you may cut the bladder before you actually undergo a cesarean section. And vaginitis, that is infection of the vagina, is not really common in healthy women, but you then find that in unhealthy women it is really common. So this fact is due to the fact that there is there's a self-sterilizing effect in the adult due to the acidic medium that is within the vagina. So this acidic medium is due to the fact that we have what you call Dodelane's bacilli that produces lactic acid from glycogen in the vaginal epithelial cells. Remember, we don't have glands within the vagina. So these are actually dependent on the activity of estrogen for cell growth and maturation. So after menopause now, you don't have the vaginal epithelium, or rather it atrophies. So vaginitis then becomes common in menopausal women, and it's also common in children where the normal defense mechanism is absent. Then you have a process that is known as caudocentesis, that is passing a needle through the posterior fornix of the vagina into the rectouterine pouch, more normally done to drain pus that would have accumulated in this disease, causing pelvic inflammatory disease or blood following rupture of the fallopian tube. But then nowadays it's also used to collect a fluid sample that is for gathering oocytes if you want to do in vitro fertilization, where normal fertilization is not possible, either due to problems with the male or rather the female or the male. So you then do in vitro fertilization, then pass back the developing embryo back into the blastocyst, rather into the female. Then we'll end with talking about the rectum and anal canals. So normally we have 3 semilunar transverse folds of the rectum that are formed by the mucous membrane and the circular layer of the muscular layer. So you find that we find 3, right? So the third valve is the one that is more important. So these semilunar transverse folds are also referred to as rectal valves. So this third valve, which actually happens to be the larger one that is known as the Houston's third valve, is important, and it's the larger one. So you'd find that when you want to pass through a cannula, either for rectal washing or you want to do a sigmoidoscope, of course you need to pass through the rectum. You usually pass it to the left lateral position to avoid this Houston's third valve. Then the lymphatics of the rectum are different from those of the rest of the GIT in such a way that they are arranged longitudinally. If you have a carcinoma of the rectum, it spreads along these lymphatics, but then it won't spread, it won't cause rather rectal obstruction because they are arranged longitudinally as opposed to the transverse lymphatic channels that are within the rest of the gut. Then prolapse of the rectum, we talked about it when we talked about loss of fat within the rectal forces. So this is just protrusion of the rectum through the anus. So it may be complete or it may be incomplete. Then talking about hemorrhoids, now we have internal hemorrhoids and external hemorrhoids. So hemorrhoids in general, they're just variceal dilatations of submucosal, anal, and perianal venous plexuses. So you classify them into internal, that are the true bowels, or external, the false bowels. So these are different. These are different in terms of what they react to and what causes them. So the internal hemorrhoids, that is the true bowels, they are circular dilatations of the tributaries of the superior rectal or superior rectal vein that is above the pectinate line, that is in portal obstruction, as opposed to the external ones that would be below the pectinate line and being tributaries of the inferior rectal vein. So they may be primary or secondary, which we talked about shortly. So they are formed due to dilatation of the main tributaries of the superior rectal vein, which lie in the anal columns. So they occupy the left lateral, then the right anterior and right posterior positions. So you find that we have one left and two right or right channels in such a way that these primary powers may be arranged in the 3 o'clock, 7 o'clock, and 11 o'clock positions when viewing the interior of the anal canal with the patient in a lithotomic position, that is flexing the hip joint. Then they raise their legs and they flex the knee joints as well. Then they raise their legs above their hip joints, and then they fully abduct them. So the hemorrhoid will consist of a fold of mucosa, then there is submucosa containing a varicose of a superior rectal vein, then there's a terminal branch of a superior rectal artery. So this will be painless unless when you then pass stool, because remember that the upper half of the anal canal is only sensitive to stretch as opposed to the lower half that is actually supplied by somatic nerves, the inferior rectal nerve. So you then find that that one will actually be painful no matter what. It won't be painful on defecation. So the types of these are your first degree, second degree, and third degree. In first degree, they are confined within the anal canal. Then second degree, there is partial prolapse during defecation, then they return. But then in third degree, they don't return, so it's full prolapse. The next for external hemorrhoid, these are dilatations of the tributaries of the inferior rectal vein, as I alluded to earlier on, and that's below the pectinate line. They're covered by the mucous membrane of the lower half of the anal canal. That means they're sensitive to pain. I remember we say so for somatic nerves, the structures they innervate, rather, they're sensitive to pain, temperature, touch, and pressure, and so forth, as opposed to those innervated by the autonomic nervous system that are only sensitive to stretch, in relation to the internal or true hemorrhoids that we were talking about earlier on. Then we have what you call fissure in the anorectal canal. So this is caused by rupture of one of the anal valves by the passage of a hard fecal mass. So the valve that is more commonly injured is known as the valve of Morgeni. You have a sinus of Morgeni on the base of the occiput. Don't confuse the two. So this, they occur posteriorly in the midline, and they are very painful because the inferior aspect of the valve is lined by a mucous membrane of the lower half of the anal canal. Remember we say that the lower half of the anal canal is supplied by somatic nerves. So fissures within the anorectal canal, they will actually be very painful. Then you also have a fistula in anorectal canal, which is caused by the rupture of an abscess around the anal canal. So this abscess will open spontaneously internally into the anal canal and externally on the surface, and the tract becomes epithelialized. So this is more like the fistula in anal that we talked about when we talked about rectal abscesses, either causing an anorectal fistula if they are to rupture into the anal canal, or if they are to if you have to protrude through the perineal skin, they would then cause what you call a fistula in ano. So I guess that's just about it. We'll I'll actually keep making more features that are clinically oriented, because I figure that knowing the anatomy only is more or so hopeless for a student, because you won't be able to apply it. So it's easier if we talk more about the clinical anatomy, and put a bit of the normal anatomy, because at the end of the day, you're learning these things to actually um, apply them as you go further. So with this, I guess I'll end my presentation here. Have a blessed evening.